So I'm feeling so happy and so proud to be invited for the second time to this meeting for my old home, or even still my home till now, Benha University Department of Orthopedics and Trauma. And thank you for Mr. Qureshi for his presentation. I'll go briefly through the tibial shaft fractures today, and this is one of the most common fractures we meet in our practice. So I'll just give a hint about history. You know, Watson Jones and Coulthard said in 1943, most of fractures of tibia will heal if treated by non-operative means. Nobody can deny this real fact, and all fractures, if immobilized for long enough, will eventually heal. Bohler also said in 1936, he recommended that all major tibial fracture be treated with a skeletal traction for 3 weeks, followed by weight-bearing plaster cast until healing was complete. But the point is, all of that also have been done about more than 3,500 years ago in Egypt, and there is here in this image, and this is found in Nagadir. It is a place about 100 miles north to Luxor, treating open fracture femur by splinting. So we'll talk first about epidemiology. There's a lot of things written here in the slide. The evidence of tibial shaft fracture has decreased over time. And regarding, if you look to the Swedish registry-based study, Weiss et al. Identified the decrease of tibial shaft fracture from 18.7 per 100,000 to about 16.1 from 1998 to 2004. And they thought the large part of this trend can be attributed to the improved road safety and the low. The average age of those with a tibial fracture is about 37 years old. It is less in men and more in women, and the vast majority of this fracture happened to the young, active adolescents around the age from 15 to 19 years old. The second peak happened over the age of 80 due to the osteoporosis. The mechanism of injury, we have two types of injury. We have low energy fracture pattern and high energy fracture pattern. The low energy result from torsional injury, and indirect trauma resulted in a spiral fracture. And at that type, the fibular fracture will be at a different level. And this is also related to something we'll speak about this later in this presentation about the Cherny grade, the grade 0 to 1 soft tissue injury. So the soft tissue injury give us idea about what the amount of energy lead to this fracture. In the high energy pattern, it's usually direct force result in wedge or short oblique fractures. And sometimes if the energy is high, it lead to a lot of comminution at the fracture site. The fibular fracture usually happen at the same level because of the velocity also. And this will lead to severe soft tissue injury to Cherny 2 and 3, grade 2 and 3, and also lead to the open fractures. Classification, most of us using like a descriptive way to describe the tibia fracture. We have the OTA-EO classification about the simple butterfly comminuted ABC. All of us familiar with this type of classification. There is also something not used like commonly called the Henley classification. It used the same rule of Winquist classification of the fracture femur, talking about the amount of comminution. Grade 0, there is no comminution. Grade 1, there is insignificant amount of comminution. Grade 2, there is cortical contact more than 50%. Grade 3, less than 50%. And segmental fracture without no contact between proximal and distal fragment. This is grade 4. But nobody used this Henley classification. There is another two important classification related to the fracture tibia is Cherny and Gastello-Anderson for the open fractures. So Cherny said grade 0, there is mild soft tissue damage. Grade 1, there is a superficial contusion or abrasion with a simple fractures pattern. Grade 2, deep abrasion, muscle skin contusion, and this is impending compartment syndrome. Grade 3, excessive skin contusion. I'm not going to details, but the Cherny classification help us to suspect the compartment syndrome. All of us aware about the Stella-Anderson classification of the open tibia fracture. We have type 1, 2, 3, A, B, C, and this is related to the amount of energy and the skin problem. Even there are some exceptions, like in type 3A, the significant soft tissue, the size more than 5, some books said more than 10. But even if we have a bullet injury or gunshot injury less than this, we consider it 3A directly without going to with the same size of the wound. So it is related more to the energy more than the size of the skin damage. So the presentation will symptoms like pain, inability to put weight, deformity can be obvious. There is some exception for weight in some tibial plateau fractures, especially in the in osteoporotic type. But this is not the scope of my presentation. There is another exception also in the some toddler fracture in the pediatric, with a spiral fracture in the tibia. The child can put some weight even with pain. Physical examination, you should the inspection palpation for deformity, angulation, any malrotation. Also, you should check the soft tissue. This is very important. Especially the tibia, the soft tissue envelope is very important for the healing of the fracture. And also, don't forget the compartment syndrome. And also, as Mr. Qureshi said in his presentation, we are treating patients, not X-rays or bone. So if you have high energy trauma, you should follow the ATLS protocol, because saving patient more important than saving a limb. Also, you shouldn't ignore to examine the neurological status of the patient of the limb, the deep peroneal nerve, superficial peroneal nerve, sural nerve, and saphenous nerve, the pulse, dorsalis pedis, and posterior tibial. And if you can't feel it, the dorsalis pedis or posterior tibial, if you have this facility, you can use the Doppler. The hand Doppler is easy, and you can access this. And you should compare to the contralateral side to see this is very important indication of possibility of vascular injury or compartment syndrome. Also, regarding the compartment syndrome, the intracompartmental pressure as measurement can be indicated in sedated or intubated patient. And usually remember, the intracompartment pressure is a delta P, not absolute value. Not look only less than 30. Yes, it can be more than 30, but if the care of the diastolic blood pressure, because this is a delta P, the difference between the intracompartmental pressure and the diastolic blood pressure. So this pressure will allow for enough perfusion for the soft tissue. So sometimes the intracompartmental pressure is not too high, but the diastolic is low because the patient in shock or something, so the patient can go to compartment syndrome. Imaging, the standard for X-rays, full AB and lateral, joint above, joint below. Joint above and joint below in the tibial chest fracture is very important. Sometimes to give you idea about the malrotation, the rotational malalignment in the X-ray. You can take also the ipsilateral knee and ankle. As we mentioned, this is very important to take AB and lateral and oblique views for knee and ankle. CT and the mid-shaft tibia really indicated, but especially in the distal third, you should do CT, because a lot of time there is extension to the intra-articular extension of the fracture and also extension to the posterior mal, and you couldn't appreciate and know this from the plain X-rays. Okay. Treatment. The aim of the therapy of the tibial shaft fracture, like any long bone fracture, full weight bearing fast, early mobilization of the patient. We are treating fracture disease, not the fracture itself. So before, as we mentioned in the history slide, they can put the patient in a cast or immobilize them for 6 weeks, 8 weeks, 12 weeks. Yes, the bone will heal, but the patient will never be normal again. So we need to reach early mobilization of the patient and early weight bearing for the patient, solid bony union, and avoid any pseudoarthrosis or malunion. Sorry. to regain full range of motion of knee and ankle joint. To achieve this, to regain the ankle and knee full range of movement, we need to immobilize the patient early. If we build if we both the patient immobilized for a long time, we'll lose the ankle and knee range of movement. To avoid infection and further soft tissue damage. And this point, uh, remember this point, why to further soft tissue damage, because already the tibia is poor bone. The cover of the soft tissue coverage of the tibia is not rich like femur. It's not covered by a lot of big, huge muscles with a good blood supply. Gastello in 1984 talked about the blood supply is weak and soft tissue covering of the tibia, and the complication can happen with treating any open fracture. Okay. Treatment. So we'll talk about the conservative management. Conservative management, the indication stable, non-displaced fracture of the tibial shaft can be treated conservatively by cast application. Sarmento, all of us know Sarmento and his PTB cast, said this in 1989. Conservative treatment in thigh plaster or above knee plaster is performed for 4 weeks, and then you can use functional brace to give some range of movement in the knee and ankle for 8 to 12 weeks. The indication, less than 5 degrees varus or bulgus angulation, less than 10 degrees of anterior or posterior angulation procurvatum, and more than 50% cortical opposition, less than 1 centimeter shortening, less than 10 degrees rotation malalignment. If displaced, you can perform close reduction under general anesthesia and bot cast. This is, I think, the trend now to, if you have some displacement, to fix the tibia, to achieve what we mentioned before, the early mobilization of the patient. There is some certain cases, the certain patient who may non-ambulatory, like paraplegic patient or unfit for surgery. This, at that time, you are obliged and you're forced to do the conservative management for these patients. So to go for conservative management, you should do serial X-rays for close follow-up for the patient. The time frame is variable. It is in general for the tibia from 12 to 16 weeks to heal, but it may be less in the younger patient and more in the older patients. So they said in the spiral lung fracture, the healing will be a little bit faster, around 8 to 10 weeks. And Meyer said in 2002 it would take about 12 weeks to for the transverse fractures to heal. Imagine you both patient with non-wood bearing for or partial bearing for 12 weeks. Due to the long period of immobilization, conservative treatment include high risk of DVT, compartment syndrome, and also compartment syndrome can be silent because you can see the skin, you can see the swelling under the cast, and the chronic CRPS, chronic regional pain syndrome. So Cooley in 2000 said treatment of tibial fracture by casting is associated with the lowest incidence of infection, but the highest incidence of delayed union, non-union, and malunion. So the operative treatment, this is the most common cases treated operatively, and there is different implants are variable. You can use this implant like IM nailing. They have it's more biomechanically stable. There is unreamed intermedullary nail can be used in the higher degree of soft tissue as like in open fracture, like Gastello-Anderson. We'll talk about this in details later now. Blade osteosynthesis, only rare indications for blade due to the huge heterogenic soft tissue damage can be found even in minimal invasive procedures, but this trend also changing now. External fixation, the use of external fixation has declined because achieving biological osteosynthesis easily can apply through the nail or plating early. And there is no difference in the infection rate or the union rate. So I will talk about the intramedullary nailing, biomechanical stability, minimally invasive approach. Evidence support that the use of IM nailing in diaphyseal fracture, it's the implant of choice. The same long time ago, about 19 years ago, by Bandari. Intramedullary nailing is indicated for open and closed isolated tibia shaft fractures, extra-articular distal tibia fracture. This include oblique, transverse, segmental fracture, spiral fractures, open fracture, even with bone loss can treat it with IM nail. So the indication for IM nail is very wide range. There is controversy about immediate intramedullary nailing or in the open fracture or using the X-fix temporary. Now the trend is going to immediate intramedullary nailing. And Rudy said in 2007, for severe soft tissue injuries, multiple trauma patient, chronic trauma, infection, non-union, and the children for nail growth, it is not indicated. But as we know, the IM nail can be used even open fracture grade 3A or B. So there is a study. The question is to ream or not to ream. That is the question. Okay, there's not experience. I quoted this from him. So there is a sprint trial done in 2008, and this demonstrates possible benefit for reamed intramedullary nailing in patients with closed fracture. And we found no difference between approaches in patients with open fractures. And also there is a Cochrane review published by 1X in 2012 outlined that there is no clear difference in the rate of major reoperations and complications between reamed or unreamed nailing. All of us putting in our minds that the unreamed saving the endostal blood supply because we are avoiding the thermal necrosis due to the reaming. But most of the studies saying there is no difference. The advantage of the reamed nail that you can give you a chance to put larger nail, so give you more solid fixation, more, and you can help to make the patient move early, mobilize early, put weight early. There's some talk about the gentamicin coated intramedullary nail. In 2011, they said there is a lot of benefit regarding the absence of deboned infection and good fracture healing and increasing weight bearing, and there's uprising air about this. But recently, Danielle in Italy in November 2020 found that there is no significant difference in terms of the fracture related infection and healing. Another technique can use the percutaneous locking plate or MIVO technique, minimally invasive plate osteosynthesis. The indication of this is proximal or distal fractures with inadequate length of fixation. So if you have a lot distal or proximal fracture, you can bridge this by this technique. And the complication is non-union and delayed union, wound infection and dehiscence. Long plates may place superficial peroneal nerve at risk in some circumstances during drilling or bolting long screws. So Hewitt et al. In 2019, the comparison between the IM nailing and the plate internal fixation method, both of them are effective, both of them achieving a good results. There is small advantage going with the IM nailing. It looks like a little bit superior to the plate osteosynthesis, but and also it is more fast and easy, and most of us are familiar with this. Some hints about the technique. For the IM nailing, the anesthesia, general anesthesia recommended, but also can go for spine anesthesia positioning. The patient should be supine, resolution table to assess the image intensifier to be used during the surgery. Both the floor in the other side of the or non-injured side. There is a pump you can put it under or sandbag under the ipsilateral hip to adjust the rotation. To don't find yourself achieving malrotation, because if you put the patient supine without sandbag or without this pump, the leg will be going to more extended rotation. You should have full access to the foot and ankle to judge the length, rotation, and the alignment during the surgery. Tourniquet, there's a debate about using tourniquet or not using tourniquet, and this preventing the thermal necrosis of reaming. But there is no big difference between using tourniquet or not. Most of us don't use it typically, but using tourniquet in vascular injury or in significant bleeding, will lead to extensive soft tissue problem. The approach, we have medial parapatellar, we have lateral parapatellar, patellar tendon splitting. We have a lot of approaches. I'm not going in details in this, but the most common one most of us using, or I use it, the patellar tendon splitting. It gives a direct access to the start point. Sometimes I'm not using it, especially in the proximal 1/3. I'll go for the lateral parapatellar because this will help me to avoid the valgus malalignment in the proximal 1/3. There is another tricks you can do, especially in this fracture, by using puller screw or block screw, or using a small fragment plate to maintain the reduction. The starting point is the medial aspect of the lateral tibial spine, just below the articular margin. You can there is some people using the guide wire first, another people look to go with the oval directly. Then you can ream the proximal part, then push the guide wire and use the flexible reamer. In the semi-extended lateral or medial parapatellar approach, we would like to go medial or lateral border of the patella, and the knee should be flexed about 5 to 30 degrees, and the choice to go medial or lateral according to the patellar mobility, and the starting point at the same like the other approach. Reduction technique, you can use traction table. Some people using the calcaneal bend to do this. Some people using the spanning X-Fix, femoral distractor, clamps. Some people maintaining the fracture, especially in the proximal third, as I mentioned, by using the small fragment plate or screws, the puller screws. And remember, puller in the proximal, puller posterior, lateral. So this is the position of the screw. Reaming. So most of studies said there is little bit importance to ream the nail. It is ream nails superior to the unreamed nails in the closed fracture. The advanced reamer slowly and high speed, over ream by 1 to 1.5 millimeter. This is to make the insertion of the nail more easy, and confirm the guide wire placed in a good place, especially if you go at the ankle joint, to be more centered, to avoiding hitting the anterior cortex of one of the cortices during inserting the nail. Locking screw, the static locking proximally and distally for rotation stability to achieve stability. No indication for dynamic locking acutely, but you can use one dynamic because the dynamization in the TBA usually we remove the static screws. The number of screws is 2 proximal, 2 distal, if less than 50% of cortical contact. And if you have short segment, consider 3 interlocking screws in the distal or proximal shaft fracture. And now we have the expert tibial nail, which give us a lot of options regarding the fixation. Fallon et al. In 2016, in their in vitro study showed that when using the expert tibial nail for unstable distal tibia fracture, the classic configuration of 2 parallel distal screws could provide necessary stability under partial weight bearing conditions, but still need more studies to prove this fact. So the treatment of open tibia fractures, we can't talk about the open tibia fracture without mentioning the post 4 or the British Orthopedic Association standard number 4. This is the guideline for treating the open lower limb fractures. It's changing a lot of things from the old practice, like the timing of the first line in this standard is to give the antibiotic as early as possible, and especially in the first 3 hours, which lead to decrease the incidence of infection Also, the routine irrigation in the ED by a lot of saline this or whatever is not indicated except in gross contamination. Also, the timing of surgery to take the patient to this to theater before we said 6 hours, now up to 24 hours, but the exception is if you have marine injury or agriculture injury or sewage injury, so the contamination will be more. So at that time, you need to take the patient as early as possible to theater. Also now, if you have a massive skin loss, this should be a multidisciplinary team, and this is the team should be formed from plastic surgeon and orthopedic surgeon, and there should be a schedule and the time frame and plan together what are the steps to be done. If you have in this facility, you can shift to early transfer the patient to another center, and this is decreased in instance of the infection. So as we mentioned, antibiotic, incision, drainage, and debridement, uh, and also this, all of this we talk about the all of this mentioned in the post 4. Also, the outcomes, early antibiotic is the most important factor in reducing infection. We must remove all the vitalized tissue, including the cortical bone. This is what we call tuck test to see the viability of the bone fragment. This is one of the cases came to me about 1 month ago. He's 35 years old. He got this injury during a motorbike accident, and we took him to the theater. We applied the frame, we debrided the wound, and we applied back dressing. So the external fixator is a good option as a provisional external fixation for the open fracture with later on for if you need plating or IM nailing. So negative pressure dressing, it is a good as a temporary measure, not as a definitive treatment for the soft tissue problem, and is mentioned also in the post 4. Irrigation by pulse lavage versus the gravity, the usual thing. There is no big difference. Even there is some study against pulse lavage because it's pushing a lot of debris inside, deeply inside the tissues. There is then the IM nailing. Morgan in 2019, and he did a case series from about 85 patients, and he found the primary intramedullary nailing seemed reliable if treatment was early with enough debridement, and you have achieved a lot of advantage that early resumption of weight bearing and low patient burden. Amputation. There is all the score, the MES score, the mangled extremity severity score, MES score, published in 1990, and there is no like agreement about the indication of the amputation. There is the relative indication for this, like significant soft tissue trauma, warm ischemia more than 6 hours, severe ipsilateral foot trauma. There is also the outcomes LEAP study done in 2010. So the most important predictor for amputation is the severity of ipsilateral extremity soft tissue injury. As we mentioned, bone need soft tissue envelope to heal, and the most important predictor of infection rather than early antibiotic transfer to specialized center to treat such fractures. And there is no significant difference in the function outcome between amputation and salvage, especially with the improvement with the prosthesis. Loss of plantar sensation is not an absolute indication for amputation. Complication, knee pain, and very common in the IM nailing, and also because of, especially with the patellar splitting approach. If even after removal of the nail, maybe the pain still persists after that. Malunion, this is high incidence of valgus and the brocarvatum apex anterior malalignment in the proximal third fracture. Varus malunion to ipsilateral ankle venous stiffness, and this is common in the distal 1/3 fractures. Non-union, the treatment of non-union is early dynamization, nail dynamization, exchange nailing. Kavaniashpan in 2020 said reamed exchange nailing is highly effective treatment modality for non-unions of tibial shaft, and the learning curve is short, and this decrease blood loss, associated morbidity, and shorter hospital stay. Also, we can go for bone grafting, non-invasive techniques like electrical stimulation, ultrasound, bone stimulator. BMP7, there is some studies say they give equivalent result with the autograft if the autograft needed. Compression plating can also achieve a high rate of union. And fibular osteotomy, if the discrepancy of the length associated with the heel intact fibula to allow the tibia to, the fracture site to be compressed and healed. Compartment syndrome, we mentioned, we talked about this before. The treatment, emergent for compartment fasciotomy. Post number 4 mentioned this also and mentioned 2 incision. Even there is a lot of studies said there is no difference between single incision or double incision, but double incision, all of us familiar with this. Nerve injury, it happened with the plating more, and the saphenous nerve can be injured, but the most common injured is superficial peroneal nerve during the use of the plate. Thank you. Sorry for long.
Thank you so much, Dr. Ibrahim, for this very comprehensive presentation. يعني حضرتك بصراحة لميت الموضوع يعني excellent, Dr. Ibrahim Bey. Thank you so much. Dr. Ahmed with us?
Yes.
You are the moderator with Dr. Ibrahim?
Okay, thanks so much. Thanks, Mr. Ibrahim, for this nice and conclusive presentation. Let's start with one question here from one of our colleagues. Is distal third tibial fracture, do we need to use a bit medialized entry for the nail to avoid varus?
What we mentioned in the entry point is the same, but we mentioned the approach itself. You know, like when you go the proximal third, you use you go the lateral incision, lateral barbatellar incision, to avoid any distraction during inserting the nail. But the most important thing, the good reduction, okay, and the position of the guide wire will achieve the good position of the nail.
The fracture, yeah.
Yeah.
One question from myself about the proximal tibial fractures, and everyone doing a nail for this will be a bit afraid of having malunion at the end. You mentioned already using blocking screws or para screws, but in comparison to a percutaneous plate, what do you think? What do you prefer, or are they comparable using just a plate which will secure a precise position without worrying about having any malunion later?
I agree with you. The using of the plate is more safe and more easy, and I think it is better. And I like to use the augmentation plate to augment to maintain the reduction, and this is also achieve a good position.
So you will put a plate over the nail or just a plate?
I bought no over the nail.
Over the nail.
Like I bought the plate first.
Okay.
I bought the plate first, and then to achieve reduction, bought the plate, small fragment plate to maintain the position, and then go with the. Even sometimes if you cruise until you passing the guide wire and passing your nail.
Okay. Another question about the pillar screws, but I remember that you mentioned lateral screw and posterior screw. Am I right?
Yeah, but like when you remember polar, P-O-L-L-E-R, so P-O posterior, L like lateral, to remember this two. Like this is to avoid the valgus and the procurvator.
Okay. Another question from myself about the conservative treatment. We used to read it, study it, but is it still really an option? Does the patient will accept 10 degrees angulation or so, rather than having near perfect reduction with the operation? Is it still really a viable option, and you get patients who accept to be treated with cast?
There is some it is rarely accepted. I think recently the most people accepting this, sometimes the old patients, like you will see osteoporotic fracture from very, very simple trauma. If they are not unfit for surgery, we'll go for conservative. And there is some patients refuse to the surgery, but this is rarely you can see this. But most of patients will go for surgery to achieve, as I mentioned, to achieve the early mobilization to avoid the other problem, the fracture disease.
Okay. Another question about the timing of doing intramedullary nailing for closed fractures. So sometimes the leg a bit swollen on the second or third day, shiny a bit. You will not open the fracture site. You will do the nailing as usual. But what about the timing if you are doubting the soft tissue?
Look, if you talk about the soft tissue integrity or the compartment pressure, if you suspect
no, soft
compartment
tissue
pressure, there is
integrity.
no way.
It's not compartment syndrome. Yeah.
Yeah. Tissue integrity will go like the open fracture, like if you have like laceration. But if the fracture, if the entry point is fine, and the place for the locking screw is fine, then you can go immediately. If you feel it is not in a good condition, you can put temporary X-fix, this one option, or you can put patient in cast with foot bump and elevation and take him to theater when the skin condition, you have the wrinkle sign and there is no blisters or whatever. But to be honest, the incision we need for the nail is, even the skin condition is not too bad, we can go for this. I think also Mr. Amir, if we can take his opinion about.
Sorry, Mr. Amir, you're muted.
Thank you very much for your excellent talk. And you raised many important topics. I think for me, what's changed is doing semi-extended position nailing. And that sorts out a lot of these problems as such with the proximal and the distal, because you can reduce it much easier. And then what I use is the humble DHS wire. And I think the most important thing is once you've got the reduction, you have to get the guide wire down and ream in the reduced position. Because if you've reamed a channel that's in varus or valgus, when you put the nail down, it will also, the fracture will go into varus and valgus. So a tip that you can do is use your DHS wire to help guide the guide wire. As you said, you can put it posterior, you can do it lateral, and for the distal ones, sometimes you go either side. And there's a rule of thumbs that you could do as to where to put your blocking screws. Again, if you just search that up, the rule of thumbs, and it will show you exactly what to do. So you just think where your thumb and fingers will need to go to correct it, and it goes opposite to your thumbs and opposite to your fingers. That can then, the DHS wire gives you a bit of flexibility then. So you can put your reamer down, you put your guide wire down, you can ream with the DHS wires there, you can put the nail with the DHS wires there. And the good thing then is that you can use a 6.5 cannulated screw over that DHS wire. So you don't have to take that wire out to put another cannulated wire because you never find a hole. You just have to see the difference in length. So say we have the Asnes cannulated screws and the guide wire is 70 millimeters longer than the DHS wire. So I take the Asnes ruler, measure the DHS wire, and then you take away 70 millimeters, and that gives you the Asnes screw length. And it's a very straightforward way to then put blocking screws. And the DHS wire, you can almost then see, okay, this is going this way. You put your DHS wire, guide the guide wire down, and then put the blocking screws inside.
Over it.
But the tibia represents about 60% of my life's work in terms of trauma, because in reconstruction, I spent 50 to 60% of my life on the tibia. My only thing is, however I'm not talking about articular fractures of the tibial plateau, and I'm not talking about pilon fractures, excluding intra-articular fractures, whether you treat with a plaster or a plate or a nail or a frame, as long as you can fully weight bear afterwards.
This is the main aim.
So if after doing your operation, you still have to keep them non-weight bearing, then maybe you didn't choose the right device.
Yeah.
I'm not talking about articular, periarticular fractures. I'm talking about, and I like to.
But you are now talking about reaming and reamed and unreamed now.
So the reamed and unreamed is that I think once you've got everything else in place,
Yeah.
the reaming and unreaming, I find the reaming easier as long as you do it appropriately and gently with patience, and especially with the semi-extended roll, it actually helps my my nail go down, but I don't ream past the isthmus very much when I do a distal third fracture, because you let the isthmic thick nail, if you have a good enough size nail,
Yeah.
the isthmus will guide the nail in the right position.
And to the center of the distal fragment. Yeah.
Yes.
Yeah.
So I think that it's a longer answer to your question, but I think by the time you're reaming, you've almost set what the end will be. For me, in my experience, the reaming
Yes, and we give the patient
end part.
You will give the patient also the larger diameter, so more stronger, stiffer nail will help him to put weight early. That if you bought a small nail, will be afraid to let patient. Okay, we'll let him to touch partial weight bearing for a couple of weeks, and this is you achieve nothing if we do like this.
See, the thing is, I am a frame surgeon, and talking about nails and tibias gives me a heart attack. but there are patients where a nail is definitely the better option. So whether your limb reconstruction, where I use plates, I use nails, I use plates and frames, I use plates and nails, and but I have to. This is the time. If I was a Christian, I'd be in confession every Sunday.
Yeah.
It's against my religion to use a nail, but I do use a nail when needed. But you do have to, it's a very technique sensitive thing. A lot of my work is undoing, taking nails out, doing osteotomies, and correcting malrotated. In my practice, malrotation is the biggest trouble with these nails. And I think a simple way to avoid that is, again, doing it semi-extended and having the other leg prepped. So you can compare the rotation with the other leg while you're doing the operation. I think the reaming, unreaming is probably a secondary issue, but I would more or less ream everything.
I will usually ream, to be honest. Sometimes, in some exception, I avoid reaming in certain cases, like if you have massive, like a huge displacement with a lot of comminutions. So I feel I should keep something, some industrial blood supply, But most of cases, reaming is a good option.
And I think the one other thing where I never use a tourniquet, mainly to reduce the heat, to reduce the heat supply. So I never use the tourniquet personally. Like I said, I'm sure as a limb reconstruction surgeon, most of my life is around the tibia. So we all have our strong opinions, but our opinions are not necessarily the only opinion that's correct. As long as you have a tibia that is rotated correctly, is roughly the same length, and the mechanical axis is unchanged, and you can weight bear them,
Yeah.
and you avoid anyone sticking them on non-steroidals. And I suppose in Egypt especially, you have to stop the shisha and the cigarettes. I think once you've done that and fully weight bear, then on the whole, they'll be okay. For me, anyway.
Yeah, thanks so much. That was a wonderful answer from both of you. Thank you. Maybe one last scenario that I have seen in many cases in Egypt, late presentation with tibial fracture, that there will be some bullies, and these bullies, either they are clear or hemorrhagic. And then after about a week or 10 days, and then you got to question, is it safe to do intramedullary nailing, or there may be risk of increased infection with this unhealthy soft tissue envelope. Again, this is away from the entry point, but it's the whole leg itself. And every time there are different opinions. What do you think about such scenario?
No, I like to go early for nailing, because if you have even if you left like hemorrhagic blister or something for a few days, you give a chance for infection to start it, so nail it. Even you use the nail in the open fracture. So
and if he presented late, so we can just frame it. I think so.
This is Mr. Amir will do this, not me.
Okay, I think we're done with questions. Thanks so much, both of you, Mr. Ibrahim Kamar, for this wonderful talk, and Mr. Amir for this also wonderful talk. I can't forget the BLRS Gala Dinner in Southampton. Wonderful one, really unprecedented. Really enjoyed it during my fellowship in Liverpool. Wonderful days, hopefully.
I hope you did the bang rank and still remember the moves.
I did. I have the photos. It was really enjoyable. Thank you so much for being with us, and thanks, Mr. Rami, for arranging this opportunity to be with such nice people. Thank you.
Thank you so much, Dr. Ahmed. Finally, I would